Ladies and gentlemen, thank you for joining us for today's presentation, Integrating Functional Outcomes with Clinical Measures, as part of the NIOSH Total Worker Health webinar series in conjunction with the NIOSH Centers for Workers' Compensation. I'd like to now turn it over to Dr. Casey Chosewood, the Director of the NIOSH Office for Total Worker Health, to start today's webinar presentation. Dr. Chosewood?
Thanks very much, Reed, and good day to all of you. Thanks again for joining the ongoing NIOSH Total Worker Health webinar series. It's my pleasure to welcome you all today to, I think, what will be a very interesting and rich discussion on functional outcomes. We're going to be joined by two of the nation's leading experts on this topic for an enlightening presentation and what I hope is a wonderful interaction with our audience on this topic. Functional outcomes is extremely important. We are all hoping for a long and healthy life, I'm certain, and we want to optimize our path through that life. And how we function day in and day out, how we're able to carry on the activities of our daily life and our daily work are increasingly important. This is a topic that's going to impact how we live, how we work, the quality of our life, the length of our life, and it's an ideal total worker health topic for us to explore. So I'm really looking forward to the interaction with our featured presenters today. As Reed mentioned, my name is Dr. Casey Chosewood. I'm the Director of the NIOSH Office for Total Worker Health. I've had the pleasure to meet many of you, so welcome back to our webinar series. I am only one of the moderators for today. However, I'm also joined by Dr. Steve Wurzelbacher. Steve is the director of the NIOSH Center for Workers' Compensation Studies, and both of our offices and centers are proud to co-present today's webinar. I mentioned that we will have two great speakers that we will hear from today. The first is Dr. Kathryn Mueller. Dr. Mueller is a professor in the Department of Physical and Rehabilitation Medicine and the School of Public Health at the University of Colorado, and has served as the residency director for the Occupational Medicine residency at the CU School of Medicine from 2002 to 2007. She's an expert in disability management and also serves as the medical director for the Division of Workers' Compensation in Colorado, where she has worked since 1992 to develop evidence-based treatment guidelines which are used in her state and several others as a basis for care for work-related injuries. After Dr. Mueller, we'll be joined by Dr. T. Warner Hudson. Dr. Hudson was the Medical Director of Occupational and Employee Health for the UCLA Health System and Campus from early 2010 until just 2 months ago, serving some 50,000 employees and thousands more volunteers and students. Dr. Hudson was previously the Director of Medical Services and the lead physician for Cisco Systems Health Center in San Jose, California, where he started Cisco's Occupational Medicine Clinic, which provided care to 45,000 plus area employees and dependents. Looking forward to hearing from both of them today. So a few housekeeping items. First of all, take note that for those of you who joined via Adobe Connect, your audio will be coming from your computer speakers or earphones. Please ensure that your volume is turned up to a comfortable level. For technical support throughout today's connection, please contact OB Connect meeting support. Note that this information that is on the screen is also available on the right-hand side of your screen. Captions are available for this meeting for anyone who would like to follow along. And if you're participating in the live webinar on July 24th at approximately 1 p.m. Eastern, please visit the URL on your screen to open the live caption feed in a separate window. Folks who are watching the recording may email totalworkerhealth@cdc.gov to request the transcript to supplement their viewing experience. One additional housekeeping slide. Much of the information I covered on the previous slide is included in the Notes for Attendees box on your screen. So please feel free to refer to that throughout the webinar. As we mentioned, closed captioning is available for this meeting if needed. Also during the webinar, you can submit comments, questions, or any problems to the Q&A box at the bottom of your screen. All presenters and meeting hosts will be able to see what you submit into the box and can respond accordingly. You may submit questions throughout the presentation. However, we will deal with content-related questions at the end of the webinar during the Q&A session. If you would like to download any of the slides that will be shared during our presentation today, you may do so as well. So just take a look below the Q&A box for the opportunity to download slides. Please note that continuing education credits are available and they're free of charge for this presentation through CDC's Training and Continuing Education online system. Note that the orange activity number is only valid for those watching the live webinar. The blue activity number is to be used only for those who view the archived webinar. And this will be true for those who attempt to access continuing education units after August 28th. This webinar will be recorded and posted in the near future for those who couldn't join us today, and you'll be able to find it on our Total Worker Health website. Of course, detailed information on training and continuing education are available for download at the link that you see. So let me just do a little bit of background setting for those of you who may be not as familiar with the Total Worker Health Program. I'll start off by saying a few words about why work is so influential to our health and well-being, and that isn't news, I'm sure, to many of you. Our Total Worker Health approach to worker safety, health, and well-being really recognizes the important role that work plays in so many of our health opportunities and our path throughout life. Not only is work directly related to the risk for injury and illness from work conditions for many of us, work perhaps most strongly is a predictor of health because it influences our wages. We know that one of the fastest ways to improve the health of any population is to give them more resources through better wages. So work and wages are inextricably linked and an important predictor of health and longevity. For many of us, work equals the benefits that we have around health care, access to health services, to income security, to a retirement plan. Work certainly impacts how we commute. And it certainly also impacts the time we have left over after work to pursue other opportunities for health. We're increasingly seeing the connection between work and relationships, both positive ones from positive interactions with coworkers and colleagues, as well as negative implications when we have a tough supervisor or we have conditions at work that do not enhance our health, safety, and well-being. Another important truth that Total Worker Health recognizes is that while work is a powerful influencer on our health, it's also a source of rapid challenge and change. If you look at the landscape of work today and employment today, it's changing more rapidly than ever. Whether it's the melding of man and machine, the rise of autonomous and semi-autonomous driving, whether it's the arrangement of how we work, the employment contract shifting from oftentimes long-term employment to one of intermittent or temporary work, all of these things have a huge impact on many of those determinants that we just mentioned, including wages, benefits, our protections when something might go wrong, such as an injury or illness. What we do, how we're employed, how we work, where we work, all of these are taking on additional significance for our health. And it's because of this complexity that we really do need to take a broader approach to what health, safety, and well-being look like for workers today. And it is because of these challenges that we have expanded our approach to worker safety, health, and well-being at NIOSH to take on this total worker health flavor. Here you can see the formal definition of total worker health. Basically, we're interested in policies, programs, and practices that protect workers from the workplace hazards, while also, beyond that, promoting injury and illness prevention, with our goal at the end of the day of increasing worker well-being. More simply put, total worker health is first about keeping workers safe, but not stopping there, then moving to establish workplace policies, practices, and programs that improve health, both on the job and off the job, with the goal at the end of the day of creating worker well-being. Here are some of the policies, programs, and practices that are at the cornerstone of total worker health. Give workers a voice in their work, attend to their benefits, wages, offer flexibility. You can see that these approaches go beyond the most traditional workplace wellness program approaches in many workplace programs. We believe that it's not possible to overcome 8, 10, or 12 hours of unsafe or unhealthy working conditions with a tack-on health promotion program or a screening program for diabetes or a lunch and learn on obesity. We advocate for deeper, more ingrained approaches to well-designed work with great attention to working conditions as the best means to improve the overall health of workers. We're also concerned about this growing evidence base between chronic disease outcomes and work, and there's more information than ever before about this linkage, and we think it makes the need for total worker health approaches even more urgent. Chronic disease is how most of us, unfortunately, will die, and we know that chronic disease risks arise both from work and non-work-related hazards, and they have perhaps the greatest ability to impact our function day in and day out over the life trajectory. We're seeing, as the slide notes here, an increasing connection between working conditions and cardiovascular disease. Some of the research we've been following says that up to 1 in 5 cases of cardiovascular disease deaths are now thought to be work-related among the working age population. And up to 8% of all cancer deaths are caused by work-related carcinogens. That's numbers even higher in men. And some cancers, like lung and bladder cancer, are highly associated with occupation and industry. So if companies get it right, if organizations approach total worker health in this comprehensive manner, what really are some of the benefits or the payoffs from that approach? We see a number of them possibly, and they're roughly listed in actually how research is showing they unfold for companies. Oftentimes some of the earliest gains that are seen from a total worker health approach is an acute reduction in workplace injury and illness, savings on the workers' compensation side of the balance sheet, safer, healthier metrics overall, increasing productivity, increasing job satisfaction, enhancing that organizational culture of trust that leads to greater retention and greater recruitment efforts, and really more informed decision-making in the long term for workers with the hopeful goal of decreased healthcare spending overall and larger societal, family, and community gains. As we start to shift into our conversation about functional outcomes today, I'll just make a few points that I'd like you to think about as we hear from Dr. Mueller and Dr. Hudson. Because work is changing, because the challenges that workers face arise both on the job and away from the job, we do need a broader, more comprehensive discussion around work and employment and what that will mean over the working lifespan. It's going to be increasingly difficult to differentiate between non-work and work-life intervals. So understanding common language and common metrics that apply both to the work and non-work setting and keep the patient and the worker at the center of decision-making in these situations is going to be increasingly important. As the population ages, the concept of workability is more pertinent in today's discussion and in the economy than ever before. It's also important, I think, to ask if current workers' compensation models are really adequate for the new economy, for the new way that we work. It used to be pretty clear-cut when one person had one job for an entire career. What about the worker who has 6 jobs at the same time, or who has 6 jobs, only one at a time, but that employment arrangement changes every 2 to 3 months? You can see how tracking worker injury and illness all of a sudden becomes quite a bit more difficult. Again, calling attention to the importance of worker-centeredness as an important baseline for all new approaches to occupational safety and health interventions, measurements, and surveillance over time. We need new metrics, tools, and other surveillance opportunities to harness the potential of total worker health interventions, and we believe that there's promise in using a functional outcomes approach in doing so. It's also important for us as public health providers to make the societal case for the benefits of better coordinated and standardized work injury care and return to work management in the future way we work. I'll just remind you all that you can continue to connect with us not only on the webinar series, but through a much more active Twitter feed, through our LinkedIn pages, and if you're not yet a subscriber to Total Worker Health in Action, our e-newsletter, I'd invite you to subscribe today. You're going to find lots of rich content, tons of resources. Just for instance, in the last edition, we highlighted 23 peer-reviewed publications that have arisen just in the last 3 months from our Centers of Excellence. So you're going to see the latest in groundbreaking research in the field of total worker health. It's now my pleasure to turn the conversation over to our national experts, and I'm going to ask at this time Dr. Mueller to come to our live podium in Cincinnati, Ohio. And Dr. Mueller, I'm going to release control of the webinar back to you, and we're very delighted to have you with us today. Thanks for joining.
Thank you so much. We are very delighted to be here. We think this is going to be an important concept in decreasing disability and basically improving the health of all workers. So it's intimately connected to the total worker health. So let's talk about where's the link here. What's the problem? What's missing? I'm not going to read through everything on this slide because I think you're pretty well acquainted with the amount of disability going on. But the estimates are that there's at least 40 billion per year lost in time away from work and compensation. And I think this is pretty disturbing, the bottom of the slide here, where it says that Social Security Administration estimates that 1 in 4 of today's 20-year-olds will become disabled prior to retirement. Well, that's certainly not a goal that we would like to achieve, right? So what can we do to change it? Let's look at some of the Washington State studies are really quite interesting. So this is one where they conducted a study of all compensable claims from 2011 to 2012. They tracked them for 2 years post-injury, and they looked at the probability of return to work after 1 year, 32%. That's only 1/3 of the people returned to work. Now, these are people who are off work, obviously, not people who didn't have disability. So once you were off work for a year, only 32% went back, and after 2 years, only 4.9% of the people went back to work. That is not okay, and it's not actually commensurate with the level or seriousness of the injury. So what they concluded was that there is a time between about 3 to 6 months when if we don't act and act in the medical setting at this point to decrease impairment and disability, we're going to have a bad outcome. Acknowledging that we're only talking about 5 to 10% of cases, but we're talking about this huge cost and actually this huge influence on society and the community. Opioids, I'm sure you've heard a lot about opioids. This one is a little bit interesting also, I think, because it's an acute disabling low back pain, and they actually only received 30 morphine milliequivalents per day. Now, if you're familiar with this, the CDC is only marking 50 as a danger point. So we're talking about people who got less than the CDC says is a danger point for opioids. What happened to them? They were disabled 69 days longer, and they had a higher risk for surgery. And in this study, they did look at the severity of the injury, so it wasn't the severity of the injury. So this is all things that tell us we really have a problem. And then this slide explains to you the lack of earnings for people. So at 9 years post-injury for workers compared to pre-injury in a different study, if they were off for 3 years, they only earned 124% of what the regular people earned, which was about 200% 9 years later. So overall, they had a $44,000 wage loss from not being able to return to work. So that's just giving you a spectrum, and I'm sure many of you are relatively aware of this. Well, we're going to talk about not just the medical side, but also there is some influence on the employer side. So one of the issues we do have is employers don't necessarily understand what the indirect costs to them are. And so when there's a work-related injury, the indirect costs that occur may be 5 to 52 times more than the insurance costs. So they tend to be looking at the insurance costs, not the indirect costs. What would that be? Well, if you look at the mathematical study, they found that 58% of employers who actually were involved in a program to return to work said it didn't cost them anything. It could cost them something, right, because they might have made workplace changes, or there might be a slight decrease in productivity. But what happens if they don't take the person back? That's those numbers at the bottom. So if you don't take the person back to work, the predicted costs of the employers were quite high, $184,000, and costs to society were extremely high. Most of you already know that. So let's get to what's exciting here. This is what it looks like right now. We have medical treatment in its own box, right? We treat it, and then the providers go, okay, done, done, oops, yep, there's an impairment, oops, I guess the person can't work, I don't know, and then it ends up in the disability box. But the things are not connected. The treatment is being done separately. So you have this box where the medical treatment is, and what we'd like to say is that medical treatment box should be focused on patient function. That should be the outcome. That should be what's being tracked. We think then I shouldn't have said disability for many, but people who end up with an impairment might end up with a disability, but they would be compensated. So somebody who has an impairment, not necessarily money, they would be returned to work, they would have better community skills, because at the beginning we concentrated on the functional goals. All right, I think this will make it a little clearer. So Marcus Welby, right? That's what we all going to be, doctors, and then we were just going to do what Marcus Welby did. What was that model? Well, we took the history from the patient, we did a physical exam. Yay, we made the diagnosis. We did diagnostic tests, we got the diagnosis, so we thought that was cool. What do? We just do whatever the treatment plan is, and then we cured them. Yeah? Well, that was great. For hernia, appendicitis, strep throat, that was great. What are we dealing with? What did we just hear? We are dealing with chronic disease. We are dealing with everything that's chronic. And in the work-related work injuries, almost everything we're dealing is chronic low back pain, chronic shoulder pain, all those sorts of things. And then in the larger sphere, cardiovascular disease and diabetes, they're all chronic diseases. So guess what? This model doesn't work. It does not end up with better care for patients or better function for patients. Unfortunately, right now, this is what it looks like when you go see your doctor, right? So the doctor's in front of the computer filling out their EHR and talking to you occasionally. That's what we got now, not that old Marcus Welby who actually talked to you. And what would we like to change from the old model, the computer? What would we like to have different? Well, we want an initial part of the conversation to be focused on the patient's functional goals and the patient's current function. So whenever the patient is being seen, that's part of the information being collected. What are they currently doing in their activities? What can't they do that they want to do? What are their work activities? What can't they do or can they do that they want to? Then that would be put on every visit as part of the treatment plan. So all the time you would be considering, when you're adjusting medication, when you're changing things, how is that affecting the overall function? You would make changes to physical activities, and this also would help all providers focus on some return to work because they're already focused on their function, right? So they're already thinking about that. So how would we accomplish this? There are already patient-reported outcome measures available, PROMs. If you look on the internet, you can find a whole bunch of them. But they're not being used. Very rarely are they being used. So if the physician was using these patient-reported outcome measurements along with their physical exam and what the patient can perform and the job duties, the likelihood that they would be prescribing treatment that both the patient would participate in and that would also end up with better function for the patient is much higher. That's what the providers look like when you tell them this. They don't know what you're talking about, and they say, you just asked me to do one more thing on the computer? You are kidding, right? And I don't understand how to use this. So what we're trying to do is move forward. There are, in fact, people using it. So this isn't as isolated. I didn't make up a new thing that there's nobody out there. There is, actually. Where are some of the areas where this is being tried? So the Integrated Care Resource Center, which is part of Medicare, is trying to integrate all these things with the idea of looking at patient function. Medicare and Medicaid are trying to integrate these things with the idea of looking at long-term services. They're understanding there's chronic issues here, and these have to be dealt with differently than we did before. And then there's value-based healthcare, which is part of Medicare right now. Again, it has the patient-centered. It has the idea of long-term outcomes. So there are pockets where this is occurring, but it's not united. And most providers do not have this as part of their care. Where is it being used? Occupational medicine, because we focus on return to work, tend to focus on function. Physical medicine and rehab, they obviously focus on function. And so we're looking at just medical specialties right now. Pediatrics actually does because they look at age-related functions for the children, right? Geriatrics also wants to focus on function because they want to make sure people can do ADL. Sports medicine tends to look at it. Much lesser extent when we get into cardiology and physical medicine. It's not as clear that they're looking at all these outcomes as opposed to just looking at lab tests or just looking at cardiovascular function. And psychology, the American Psychological Association, is strongly involved right now in looking at patient-reported outcomes. What other elements do we have? Now I want you to consider this one really important part, the second part on the slide here, which is that virtually every evidence-based guideline and all peer-review articles in the areas that we're concerned with use patient-reported functions as part of the outcome. So right now in the scientific evidence, that's a requirement to get published. If you're doing low back or arm, shoulder surgery, or any of those things, you have to have this information. So you might ask me, why is that not in clinical practice? Well, that's the question we're asking. Why is that not in clinical practice? If that's what we're looking as an outcome in the science literature, we should have it in clinical practice. So who started to put this in? Well, we've tried in the Colorado Workers' Compensation System to put it in. The ACOM guidelines reflect this evidence-based, function-based outcome. In fact, most of the workers' comp-related guidelines do reflect a functional outcome as part of how you decide what to do for treatment. Here are some programs that exist right now that have these as incentives. So the Washington State program and their COHE models, their occupational health and education centers, have return-to-work coordinators that are looking at the function continually of the patient, helping people return to work. They're paying the providers for doing that. In Colorado guidelines, we pay providers for collecting the functional outcome measurement and using it for treatment. Both models, Washington and Colorado, try to decrease the pressure on the doctor when they do this. So less prior authorization requests and other things because we know they're already compliant with the treatment plan. So they're not being hassled as much by the insurer. We have additional payments. So we pay them additionally for functional tools. We pay them additionally for the opioid reports that have the functional tool in them. We penalize insurers who don't pay attention to this and who hassle doctors who have already done what they're supposed to do. In summary then, what we're saying is that the functional status translates to a workability and increased physical and mental health. And if we would concentrate on the functional goals and all the providers were oriented toward those rather than an isolated lab test or an isolated finding, that we would improve the care for the patients. And providers actually can't help return to work if they don't look at this functional thing, right? So they really can't make those decisions. So it affects return to work, and it also should improve the overall health status. So I just close with this is the World Health Organization's definition. It happens to be for mental health, but it's basically overall health. A state of well-being in which every individual realizes his or her own potential, can cope with normal stressors of life, can work productively and fruitfully, and is able to make a contribution to her or his community. That's what we're looking for. We're looking for increasing the functional life of the patient, both at work and in the community, and therefore the overall health of the patient. And we know that that actually can decrease medical costs and decrease disability. We don't want to say there's no other problems, so I'll just leave this slide up here as a secondary thing we do have to think about. Even if we manage all of that, we would still have to help employers be more incentivized to take people back to work. There are states who have programs like this that could be part and rolled into the functional thing where we help employers take people back to work. And there may need to be some other changes, at least in the workers' comp system, to further incentivize. But we think the main missing piece is this lack of focus on the function of the patient and the patient's well-being as an outcome in basically the chronic illness. So, and these are this list of some references. So Dr. Hudson is going to give us a very interesting discussion of the study and work he did in this area and how it impacted the medical costs and disability.
Thank you, Kathryn, and thank you, Casey and NIOSH for inviting us here today. Total Worker Health is a wonderful program, and Casey is a wonderful leader of this and got a great team, and it's also near and dear to my heart because My initials are TWH. So I'm going to talk about a program we developed over the last 6 years at University of California, system-wide, 10 campuses, 250,000 employees, where we took workers that had had 2 or more work comp injuries and put them into a personal health improvement program with fitness coaches and with registered dietitians, life coaching, EAP, wellness, et cetera, and looked at really a surrogate of functional outcomes, which is fewer work comp claims and less cost. It is a surrogate. It was not designed as a study of function, but those are the measures we could get, and I'll talk to you about how we got there by way of giving you a little bit of background into how we got there and then how we did it, and then show you the results. So that's what we're going to do. So I'll talk about the background, some examples, focus on health, adding functional outcomes, set the stage for the Work Strong program, which is the name of this program I described at UC, and then how it has panned out, and then some takeaways. So Churchill, interestingly, said, healthy citizens are the greatest asset any country can have. We all agree with that. So the strategy by employers with employees and health has moved to a focus of the benefits of health as opposed to the cost of health care, the cost. And I think that's really important because this sings with employees, whereas telling employees to focus on the cost of care makes them run the other way. Sequence matters, as Casey indicated. Things have to be safe work and healthy work first. Then you can focus on personal well-being and so forth. And we need to add improved function as well to this model, because really everyone at some point in their life or multiple points will have or acquire or is born with limitations. And so we really have to learn to adjust work to these limitations so that people are able to be the most functional in spite of their limitations. And people look around, they follow what people do. They know if you care, and they know if you're walking the talk. And so we have to do things differently than the way we've done them in the past. So this is a CDC shot of the Total Worker Health landing page, and I just added the yellow part that functional outcomes should become a key part of this. As Kathryn mentioned, about a fourth of adults in the U.S. have at least one chronic condition. Another fourth has 2 or more. It's hard to know the burden of functional impairment as opposed to just chronic conditions. It's not routinely measured in clinical medicine. It's measured in research, but we haven't integrated it into the clinics. We use it somewhat in return to work, physical therapy, occupational therapy, OCMED, PM&R, psychology, psychiatry, IMEs, AMEs. So we just need to begin to think about how do we improve our focus on functional outcomes. Whatever measures we pick and decide to use, they should be validated, accurate, quick, and easy to use. That's the top line, but it's really the bottom line. There are, of course, challenges with self-reported questionnaires because of biases, performance testing, which people, effort changes them, and they have some day-to-day variability. Integrating into workflow and doctor practice, provider practice is a challenge because people are already overburdened with all the things to put in the EMR. To add one more thing to collect, whether it's front office questionnaire or the doctors are doing it, is not going to be easy, but it's very important to do it. So in the meantime, we're using functional outcome surrogates, or we're using work comp claims and work comp costs, absenteeism, presenteeism, activities of daily living, which may or may not focus on work. Whatever tools we use ought to be reimbursed and required. They ought to be woven into the workflow and to the electronic medical records. We're not there yet is an understatement, and we're starting to work on it is really what I'd say. And I'm just going to show a couple of screenshots of what is going on globally. ICD-10, if you go down to the one in red, has something about function. The WHO WOHAS 2.0 at the bottom has a bunch of domains. If you see the second to the bottom dot, it says life activities. Domestic responsibilities, leisure, work, and school kind of all jammed together as one. I don't know how many people in the field are used to this particular set of measurements, but it's out there. It's part of the WHO ICF. And as Kathryn mentioned, Medicare has functional outcome measures built into the MIPS system. And of course, the old AMA guides have had people doing all kind of measures of permanent impairment for really legal compensation reasons. And this is very specific in detail and not what we're talking. We're talking about more global overall function at home, at work, etc. So the reason we feel like these functional outcomes and progress measures are important is they do help with setting goals and measuring progress along the way of any intervention. It does help with education and awareness when you're working with a patient. It helps with motivation to talk about function as opposed to only talking about, doctor, I want no pain. It helps with setting restrictions and limitations. It's a guide for return to work and other activities outside of work, whether it's therapeutic or preventive restrictions. It helps guide treatment and treatment efficacy. You know if your treatment is working, if people are functionally getting better. If they're not, your treatment's probably not working. Helps prognosis, helps with assessing disability and legal issues. It's increasingly going to be a justification for payment and continued treatment. It's needed for research, and eventually we'll have apps and health risk assessments that include more about functional outcomes than they do currently. In occupational medicine, as one example, we include functional restrictions or limitations. They may be preventive in nature. They may be therapeutic. Ideally, they're based on the medical conditions themselves, and they're adjusted at each visit, which may be often or less often. The task assignments and the accommodations to these restrictions really are the work of the manager and HR, whereas setting the restrictions are the work of the provider. We do in OCMED use tools, weighted lifting box, grip and push-pull dynamometers to set with more accuracy when we need it, but you often don't need those. But there's a lot to be learned, and we ought to also be sure we're focusing on what the person can do as opposed to what the person cannot do either temporarily or long-term. There was an interesting study out of Colorado from Schwatka and a whole group of people that was published last year. They looked at about 317,000 employees of 314 employers, and they looked at health risk factors relative to work comp claims, and they adjusted them for demographic and work organization factors. And what they found was that work stress predicts work comp claims quite well. P was 0.07, not quite as predictive in terms of the p-value as home stress, which predicts higher claims total cost at a P of 0.01. The other health factors washed out, which was pretty interesting. This is an old D. Eddington slide, and it simply shows that risk at all age brackets trumps age. And so across the age spectrum, it's risk, low, medium, highest reported on the health risk assessments that D. Eddington has published since 2000 and before. These are the dollars from 2001, and so you see as health risk tiers go up in every bucket, short-term, work comp, long-term, absence, pharma, and group health, the costs go up. And he also showed that as you decrease the risk, the costs go down. And this is just breaking out the work comp part. Again, this is part of the justification of why we put in place the program. These are personal health risk factors impact on work comp, and this is really part of why total worker health exists, an integration of health and safety. This was from Vanderbilt. They saw their work comp cost go down as wellness scores, increasing wellness, went up. This is from Mary Yarborough from, oh gosh, this slide is probably 7 or 8 years old. And as Kathryn pointed out, a lot of the costs of these are hidden in indirect costs and presenteeism, absenteeism, short-term disability days, and so forth. And let's see. Microsoft has stopped. I'm not going to dwell a lot on these slides. We've lost a couple of minutes with that glitch. Certainly, we found that the cost, indirect costs of the bottom of this big iceberg of injuries and illness is far more than the direct cost. So we know that's true. As I was beginning to show on the previous slide, Before this, stress is one of the biggest problems in the workplace that drives a lot of other things. The Joint Commission, as may have been mentioned, has a booklet out in 2012 showing this nexus between improved patient safety related to employee safety and employee well-being. And so more on that later. So back to where we're headed with all this. The context at the University of California is that we have system-wide tobacco-free. We have this Work Strong program that I'm going to describe in detail at all the campuses. Some have diabetes prevention programs on the campuses. UCSF got rid of sugar beverages. We have Healthy Campus initiatives at the different campuses. Healthy Campus Network, UC Office of the President, has beefed up its well-being core resource team. We have healthy vendor criteria, wellness coordinators of each campus, all kinds of provider initiatives, a lot of benefit and wellness offerings that are linked, employer health exchanges, and so forth. So that's the context into which we put this thing. And we know, as we look at our work comp claims, this link between personal health risk in a dollar fashion. One comorbid condition, two comorbid conditions, three comorbid conditions. So the more personal health conditions accumulate, the more the work comp claims cost. So at some point we need to work on the personal health. And part of the way we've been moving the last few years is integrating safety and health, and certainly if improving personal health improves the outcome of work comp injuries, it's a far better deal. It's a hard task to do that because changing human behavior is hard. There are a lot of layers to changing health. And, of course, the Freedom Pyramid says if we're going to work with individuals, we're working at the very tip top of this pyramid, not at the more broad-based things that work. So it's hard farming, as they say. And even if we look at our strategic goals and objectives, we often don't find that health, well-being, and things like that are part of the fabric of our organizations. And that's really a culture change that we should be moving on. And changing health behavior is indeed hard. This is sort of what the organization typically looks like in terms of complexity. This is what the employee hears every day and sees in terms of sorting out what should they do. But we do spend a lot of time at work. America is one of those wiggly lines at the very top in terms of hours at work. This is a slide that I put together many years ago, just looking at the spectrum of things you can do to look at health improvement as an enterprise strategy. And back to UC. In the U.S., employees spend about 1,600 hours a year at work. At UC, we have very long-term employees, concentrated work geographically, a lot of commuters, very diverse culturally, economically, but lots of leading well-being research and expertise on site, good health plans and doctors, the Healthy Campus Initiative and Network, a fair culture of health where pockets of it are outstanding. The challenge of reaching the 90% of people who don't participate in all the well-being efforts. But the point is there are a lot of things that are going on aside from this program, Work Strong, which really we looked at D. Eddington's research and we said, boy, if we can improve personal health, I bet we can improve work comp outcomes and have people at work more. So UCSF did a pilot. They put 72 people through a fitness coach program, just improving personal fitness. And lo and behold, those people didn't have claims again. Followed for 3 years. And I'll show you in a minute why that's not what we would expect. Have a stable long-term health force. So it was decided that you were eligible if you had 2 or more work comp claims in the last 2 years. And we know that there's a stair step of claims costs going up with each subsequent claim being more expensive than the previous one. So we said, let's improve personal health. We think that's going to decrease claim costs. We started in 2012. We offer the injured employees intensive personalized fitness coaching for about 20 weeks, meeting with a registered dietitian for about 10 weeks, life coaching through EAP and other wellness efforts available at no cost to the employee, free gym membership for 6 months. So again, this is intense, and we talked about the eligibility criteria, and we made participation voluntary. Even though it was referred as PHI-like to physical therapy, we didn't say you have to do it. So they're screened by our OCMED providers for the medical conditions, screened by HR to to make sure that there's not an impending lawsuit. The work comp coordinator invited them from the doctor's office of Ahmed to participate on their own time. They're medically cleared. An individualized plan was created for each, and then the focus was on function, to become healthier and to do what you can do given the situation you have, as opposed to the physical therapy approach, which is let's improve the shoulder that you injured. This is a much broader program. And notice it's not a clinical diagnosis-based program. But we took people who had MS, who couldn't do things out in the heat, put them in cool water swimming programs. We had a lot of different programs to do stuff. So this is the timing. I mentioned this before, so I'm going to scoot past the content portion. So in April of 2017, we had about 1,800 enrolled, and we had about 1,000 graduates at a cost of about $2,000 per person. The yellow box at the bottom is what it was a few weeks ago, approaching 2,500 participants, about half of whom have graduated. And so the program is really across all 10 campuses done well. This is to back up a little bit to show you the stair step. We know from our claims data that if you have one work comp claim, the odds are good, about 1 in 3, that you're going to have a second claim. And guess what? That one's going to be much more expensive than the first one. Third more expensive, and fourth more expensive. And people have a lot of claims. This is a list of how many of the overall claims at UC are people who have multiple claims. So the idea was if we can get ahead of this train and somehow change this behavior, the same way that we work with hot spotters on the group health side, whether it's congestive heart failure or asthma or any of the other hot spotter conditions, and keep them out of the emergency room, so to speak, and instead get them healthier through intense work, hard farming as we think of it, we might see a difference. But how much would we need to save to make it really worthwhile? What we said is that we had to save about 12.5%, 12.4% of claim cost for this to be worthwhile at a cost of about $2,100 per employee to go through the program. And so what we actually, this is numbers of claim, not cost. I'll come to that next. So Bickmore is an actuary that runs these numbers every 6 months for UC Office of the President to see if the actual work comp claim numbers and claim costs in work comp are different from the expected, that is, the group that didn't go through the WorkStrong program. And this started in 2012, so 2011 is really a beginning year, 2012 a beginning year, 13 barely off the ground, 2014 you start to see impact, 15 and 16 the impacts start to become more. So 9% fewer claims. So you're not decreasing the claims a lot, still 9% is quite significant. The costs are what are dramatic. So you see from the beginning, the actual costs are much less than the expected, 28% now out at 6 years from the beginning of it. So, and this is a lot more than the 12.4% we needed. So it's more than double what we needed to do to break even with this program. The other sort of non-quantitative outcome of this is that people said, that managers would say, so-and-so is back at work after being off for months. They're engaged, they're eager, they're active. They thanked people. We had ortho specialists saying, gee, once they're in this program, since I don't have any more surgery to offer them, they used to come back and come back and come back. Now they don't need to come back and see me. Thank goodness, because I didn't have anything to offer. So they're referring patients into this kind of a program. So we used in a big sort of hybrid, decentralized, dotted line matrix organization in the University of California is we had to use the Stanford Collective Impact Model approach. People leave their agendas at the door, agree on a common agenda, agree on common metrics. We had strong top-down support from the UC Office of the President, along with the Ahmed directors. We hired WorkStrong coordinators at each location, and we utilized our in-house service providers as much as we could. A lot went right. The employees being selected and reached out to by the Ahmed office felt okay to the employee. It wasn't the insurance company or some vendor unknown to them who was reaching out to them. It was, this is Dr. Hudson's office calling. We've invited you into this program because we've seen you've had several work comp claims. We have a program to improve your personal health. We think it'll improve your personal health and make you less likely to get hurt again. Are you interested in? It takes, frankly, an average of 4 phone calls in a month to recruit people into the program. So it's hard work. It's intense. It doesn't scale with an app that easily or quickly, and I think all the investor world is interested in scalable apps that are quick and that reach millions of covered lives right away. Changing human behavior is a little tougher than that. I think we're all aware of. So we would get the names of the people that were screened in from Sedgwick. We used our UC trainers, fitness trainers, registered dietitians, EAP. It was on people's own time. It was PHI, so when managers or unions said, is so-and-so participating, we'd say, it's between the person and themselves. We're not going to reveal it. There were challenges along the way. Enrollment, like I said, is labor intensive. Tracking dollars in and out of the spend, we didn't do the first couple of years. We had to go back and retrieve that to know exactly what the costs were and figuring out what to do once people graduate because, like I said, an average 20 weeks in this program to change somebody's life for good, which is what we want, and then to sort of leave them out there didn't seem right. So we're still struggling with what to do next. So one thing we did is we put together a Center of Excellence with UC's help, UC Austin President's help. Allison Frink, who has done the yeoman's work of running this Center of Excellence, has done a great job to standardize things at all the campuses, help people learn best practices, help make course corrections, track dollars in and out, create training materials, handbooks, work with the partners locally to make sure they're engaged, partners being people on the campuses that may have the fitness trainers and so forth, the local docs who may be seeing them. And we've lowered the bar a little bit so that on a case-by-case basis we can let someone that's had just one comp claim get in the program, maybe somebody that's heavily overweight, et cetera. And so with sort of more work with the Center of Excellence, we increased the number of enrollees per month, as you can see. In fiscal years 15, 16, 17, we doubled the number of eligibles who were actually enrolled, and we increased the consistency. And so next we want to improve the way that we learn whether this impacts group health costs. Just before I decided it was a good time to retire from UCLA, we had gotten funding to look at the group health cost claims of the people who had gone through WorkStrong, see if before and after the group health costs went down. D. Eddington's data and others would suggest that as you improve the personal health, it improves work comp. One of the first things to go down, it would naturally decrease the other buckets, but we didn't get a chance to run those data. Truven was going to run it. We'll see if that gets done. Now that I'm not there to sort of push it forward and nudge it, shepherd it. I talked about the challenge of the graduates and what to do and how to remind them. We talked about apps. We did an HRA screening program with it. Once they had this kind of intensive, custom, hands-on program, the phone call in the evening and the HRA stuff just didn't resonate with them, so that didn't turn out to be so well. We did find out that when we were building the diabetes prevention programs on campus, we leveraged what we learned with the WorkStrong program to create the diabetes prevention programs. And coincidentally, I figure most of you are familiar with the diabetes prevention program. The typical time that you want people to spend going through the diabetes prevention program is about 16 weeks, right? CDC says you're a starter at 4 sessions, you're a finisher at 9 sessions, but the goal is 16 sessions. So it's a very similar health behavior change time frame to ours, which we had thought was going to be 17 weeks. It turned out to actually be 20. But these are injured workers. They have more than the run-of-the-mill set of life challenges in terms of transportation and finances and so forth. So that's not unexpected, but it's close. This is also what Wendy Slusser, who is a physician, pediatrician at UCLA, who's done a lot of work on childhood obesity, found in designing programs to help parents of obese children get their kids' weights down. She found it took about 17 weeks to do that. So that seems to be kind of a, I mean, I think of it in the farming metaphor that, you know, when you select the ground, till the ground, water it, fertilize it, sunlight, time, it takes time for us to change our doggone behavior, us human rascals. So there are a lot of other things we have to do. At UC, this was one of many programs. And sort of maybe the highlight slide for you just to sort of file away in the back of your brain to think about how do we do this is there's that health spectrum green horizontal line from the healthy, super healthy on the far side. And at the other end, you accumulate risk factors, conditions, adverse events, chronic disease, and so forth. But at each level, there's super high all the way down to low and non-functioning. And that thing slides back and forth like a slide rule. And really, there are people who are functioning extremely highly who have, through luck of traffic accidents or genetics, had very severe impairments, blindness, or been in a wheelchair their whole life, and they function very highly. So we need to sort of figure out how to keep the function arrow going up regardless of where they are. And somehow in all this, the joy in work needs not to be forgotten. And so takeaways, focus on health and function as a part of health, develop broad, validated, quick functional outcome measures that can easily integrate into clinical work at each visit, but remembering that things like WorkStrong aren't necessarily diagnostic condition-based. They are more broad than that. So our programs could be more broad than that. Had we put into place with WorkStrong functional measures at the beginning and every step of the way, I don't have the data, but I'm convinced that we would show function improving because people are more at work and they're having less claims. And they're not being cajoled back. It's purely voluntary. Clearly more research is needed. We need to ensure our payments, records, and training support these efforts. And I have a list of resources, and I think now we have time for Q&A. And so I'll invite Kathryn back up. And you're going to...
Great. Thank you guys very much, Dr. Mueller and Dr. Hudson. That was excellent information. And Warner, also thanks for enduring those technical difficulties there. You handled that like a champ. I would like to welcome to the webinar my co-moderator, Dr. Steve Wurzelbacher from our National Center for Workers' Compensation Studies. Steve, are you ready to head into Q&A?
I'm ready here. Thanks, Casey. As Casey mentioned, please go ahead and submit your questions for our speakers to answer. And you can do that if you're just joining by typing into the questions into the Q&A box. I'm going to actually repeat the question that has been posed, and if it's directed to a particular speaker, I'll indicate that. And as we go through, I'll also open it up to the audience we happen to have here live as well. So for the first question, and this is for either speaker, the person asked, I've noticed a lot of differences between work release forms. Are there standard workability and work restriction forms that would be easier for the physicians to use that would facilitate a focus on recovery outcomes rather than injury?
Well, that's a great question, and thanks for that. There are some standard return-to-work forms. You can get them at many places. England actually went through a whole work note, changed it from a sick note to a well note, I think. Do you remember the name of it? Anyway, they changed it to a standardized format across all of England. Dame Carol Black headed up that effort. The Department of Workers' Compensation in California has standard return-to-work slip for work injuries. But the truth of the matter is that the average primary care doctor sees about 9% of his or her practice as return-to-work note type patients. And as someone that trained initially in family medicine at UC Davis Medical Center, we had very little training in that. And so a lot of people were filling out a lot of forms and basically saying to the patient, what do you want me to put on here? And that's where we get, you know, the jokes about Dr. Summeroff, doctor, I want the summer off kind of thing. But there are some reasonably good return to work forms out there, and I bet ACOM has some if we dig deep into the website. Kathryn?
So we have one also on our forms in Colorado. But I think from the teaching point and what we're trying to focus on for all providers, so interestingly enough, there's been some studies out there that talk about what do patients not get from their providers. And one of the primary things they reported, this was not in a work-related injury group. This was just in a regular patient group from their primary care providers. What they said they didn't get was what activities should they be doing and what should they be doing at work. This is from the patients. So patients are actually missing that information. And so we're trying to get, if we put function right in there in the record, that the doctor will then talk about what activities should you do and not do, not just related to work, but in order to recover. So that's really where we're trying to go with that. And so we think it should be part of the treatment plan, whether or not it's a work-related injury.
All right, next question. Again, this is for either speaker. Because many of the patient outcome studies continue to use return to work as a measure of success, not distinguishing among return to same, modified, or other work, is it not possible to assess employer-based factors in the outcomes? Is there a way to incorporate this data?
Well, again, more research is needed, but in a lot of databases, you can tell whether someone returned to their original job or whether they returned with restrictions. I know we can internally at the University of California. I suspect other large employers can track that, but that's probably not well enough published. So I agree with the question.
There's also the interesting RAND studies that were done on work-related injuries. And what they looked at was whether or not there was any permanent disability payment. Now, we all know that differs from state to state, but they were looking at that, and then they looked at the long-term outcome. And the outcomes are somewhat similar as to what I was showing you in terms of loss of wages. So if any permanent impairment is shown, even when the person goes back to work, their long-term loss of wages is quite large. So it's important for us to focus on this with the initial injury.
Right.
And one last comment on that. Again, these are surrogates of really measures of function, which is what we want to get to. And we're all struggling because the surrogates are very imperfect. They're what we have, so it's what we use.
All right, so next question. This is for Dr. Hudson. Can you provide more details about the types of functional capability evaluations performed? What worked well and what did not work well? And do you have any advice on choosing types of tests?
Yeah, I'm going to let Kathryn comment on this one, too, because, on return to work, a lot of it is sort of clinical evaluation, and we used lifting boxes with weights. We used hand push-pull dynamometers, things like that to get a sense if we needed more specific information on what people could and couldn't do. With the WorkStrong program, switching gears a little bit, everybody's injured, so everybody's going to a fitness center that takes care of college and grad student people and some faculty, used to relatively dedicated fitness-oriented people, and they're switching to adding people that are often overweight, not necessarily all delighted and happy, who have some injured body part or many injured body parts, and trying to work to improve the fitness of that. And so there's a lot of specific things that the fitness coaches do to assess what they can safely do and not. And I think it'd be good to hear from athletic trainers about that, because I heard again and again and again for 6 years, people would come back from their first half a dozen sessions with the fitness trainers and go, gosh, I never knew how to work out safely. The physical therapist worked on my shoulder, my ankle, my quad strength or whatever, but I didn't know how to work out safely and get fitter overall. Thank you for, getting that set up. So that's only a partial answer to the question. Maybe Kathryn can add to that.
So I do think this is complicated. It turns out, again, if you look at the literature, that straight functional capacity evaluations actually don't do a very good job of either predicting who's going to get hurt again or who's going to stay on the job. So there's no nice little Bible answer here that we'd like to have. And so it does become important to do just what Dr. Hudson said, use the physical therapy results in coordination with return to work. Personally, as a clinician, I found it was easiest to gradually return people to work in coordination with the physical therapy exams in their report, and that for most people that's going to work. I think for really complicated cases, they need to be referred to an occupational medicine specialist or OT or some other people to help you. But when you look at the vast majority of people can go back to work, using these simpler manners would probably work.
All right. So this next question actually refers to the UC program, UCLA. So is there any provision for wellness among UCLA employees that haven't had a workers' comp claim? And if so, is it the same program that those who are in the program use?
It's a great question, and I apologize if I went a little fast at the beginning. There are many, many programs throughout all of UC. WorkStrong is all of UC. It's not just UCLA. At each campus, there is a Healthy Campus initiative, which has people from all parts of the campus giving input on mind well, fit well, built environment, connect well, which relates to the fact that people's social connectedness is a risk factor as powerful as smoking in its absence, and so forth. Those are aggregated together in a Healthy Campus network, and many people, Wendy Slusser, Julie Chabdi, have helped to make those programs alive and well, and they're available to all employees at no cost. And if you go to healthy.ucla.edu, you can click on the details of the actual UCLA one, and I assume that you can do that for the other campuses as well. The plan was to have one entry-level portal that would lead you into all the others. But that exists in the background. It ramped up over the last 6 years as well. But the non-participants in WorkStrong would have had access to that as well as the participants, so it really wouldn't have changed necessarily.
Okay. And a follow-up question was, would that type of program be compatible with federal workers' comp? I think the person was actually asking in reference to the UC program, but also in general functional outcome tracking broadly.
Oh, I think absolutely. You know, a program to improve personal health, if you had a work injury that's voluntary, I think so. I think the challenge is that we use a lot of local existing resources, so it works best when you have employers who have a bunch of people at a site and have some of these services existing. A lot of places have fitness centers, they have fitness coaches, they have registered dietitians, or they can hire them part-time or full-time and put them in place. So I think it's not as hard as it looks. It is harder for like a franchise type operation where there are lots of little small sites, Bank of America or In-N-Out Burger or something like that. I guess that's not a franchise, but where you've got a lot of small sites, I think would be harder.
Okay. And then another follow-up on the UC program. Besides appointments with registered dietitians, EAP, and gym membership, what other services were part of that program of WorkStrong? So
the smoking cessation programs were offered. There wasn't a lot of uptake because, frankly, it's been a smoke-free campus throughout UC since 2014. So that was available. Only very few people took us up on that. But we also took the opportunity to encourage people to go through all the other wellness offerings that UC has that I mentioned through the Healthy Campus Initiative and Healthy Campus Network, so that they were at least made aware. Because honestly, if you're a nurse or driving a bus or working as a gardener, you come to work, you plug in, you work, you jump on the van pool, and you go home, and you may not have time to get on your computer and learn about the wellness offerings that are easy to access. They might not be so easy to access, but you probably aren't even aware of all the things. I mean, it's like most workplaces, it's complicated to know all the things that are offered. And we found that once somebody started in the program and had success with WorkStrong, other people would join. Like we had one policewoman go through the program. She told all of her friends, and then several more of the UC police came through, and pretty soon there was a dozen of them. And so each time we'd make sure they were aware of all the other wellness offerings, and so it sort of has an echoic effect of you start here, you get into the room, and you begin to expand.
All right. And this question's for either speaker. So the question is, I work in the seasonal industry. One of the problems we face with return-to-work programs is that we see an increase in injuries, illnesses when it comes to time to reduce hours or lay off people. The return-to-work workers are guaranteed their hours, and it picks the culture of fraudulent claims. Do you have any recommendations to handle these types of situations?
That's always a challenge. I've known some employers that have ups and downs in work that simply hire their people year-round. In construction, for example, they found that they couldn't get the best workers to do the parts of the trade, electricians or tile people, if they let them go and then tried to hire them back, and then they'd have claims shortly before they went into a low spot. And the result was one employer wound up with, they had all the best workers, they kept them year-round, so they were full of good work all the time. So it was kind of a, counterintuitive. They thought it would be more expensive, but it turned out to be really an advantage to have the best work and the best workers. But it is a challenge. I know I hear this from the movie industry in terms of people, they're off the movie, and so just before the movie filming stops, there's a couple of claims, and I think it's a challenge. Mm-hmm. Kathryn?
All right. This question is for either. Can you give specific examples of functional outcomes that were identified by participants or patients as goals? So in other words, can you give examples of functional outcome goals that were either set in the course of care or as part of a program?
I've talked too much.
So let me explain a little bit. I didn't really get to explain about what the Colorado program is. So the providers are allowed to use from validated physical function tools that are patient-reported, like we talked about, and then also there's the psychological screening tools, and they're required to use both of those. So we actually have some outcomes from some of the shoulder. This is an observational study, not a randomized controlled trial, so I didn't put it up there as evidence. But it worked quite well in them being able to identify quickly when people were plateauing and not reaching their outcome that they would have expected. And they also had expected outcomes for some of these, so they sort of know, well, okay, say you had a knee replacement surgery or you had rotator cuff tear, they actually have an idea of what the normal trajectory is for the person to be functioning. So as soon as they plateau or something happens, they go back and they find out why. One of the case histories was they found an infection that nobody suspected from an implant because the person plateaued and they wouldn't have found it as quickly. Another one really was more of a kind of behavioral thing, having a discussion with the patient, explaining that you're not at the same level, and in Colorado, you can continue to get treatment if you just are plateaued, right? Because then you're at maximum medical improvement. So having a sincere discussion with the patient about what they needed to do, how most people reached this higher level, and we would expect that they could, but in order to continue any treatment, they would have to start to show some functional assessment. So it really encourages discussions with patients working towards specific goals. Now, if you're aware of some of the other options, we don't happen to approve this one because we're having them use validated tools that are used in research. But there's also commonly used one where you ask the patient to set their own goals. Now, you have to help them because they have to be able to set a physical, measurable goal. But you can ask them to do that, and then you can follow their progress to the patient-created goal, and that's another accepted way of going about it.
Another way to think about it is if you have a hospitalized patient who's really not able to be mobile, a first goal might be to sit up. Another might be to sit up with legs hanging over the bed. Another one might be able to get up and sit in a chair beside the bed. Another one might be to walk with assistance. Another might be to walk with a walker without assistance. And then you can gradually increase the distances from, one time down the hall to the elevator and back to all the way around the ward. And then up to a couple hundred yards, and you can sort of take that logic and work on it with any patient with any condition to sort of look at functional goals that are specific to the patient's situation and that are meaningful to whatever they have. That, I gave you a more inpatient example, but you can do the same with outpatient.
Okay. This question is for Dr. Hudson. Did you have any legal issues offering benefits for the Work Strong program to only certain employees and not others? Essentially, that's generally not permitted in private programs. Perhaps as a public employer, the state university system was exempted, and was participation voluntary? So second question.
Participation was voluntary, and it was not considered a benefit the way benefits are housed under human resources. This was in the risk management department, so this was really a program to decrease the likelihood of injury the way any safety program would do. So I think we had to be careful with the rubric of the program and not to label it a benefit, a negotiable benefit the way the question was asked. So we steered clear of that, and after 6 years in what is a very contentious environment, if you read the newspapers in Los Angeles, strike every 6 months or so at UCLA and then some at different campuses, usually around wage and benefits. We didn't find any problems with the Work Strong program. So it steered clear of that by being a win to everybody, to the worker, to managers, to the university itself, and it stayed confidential, and so it's been a successful program, I think, in part for those reasons. But an important question to not sort of step into the wrong zone and call it a benefit or mandate that people go through it, at which point it becomes a bit of a different creature.
Right. So this next question is for both speakers. So increasingly, disability and absence from work is related to mental health and mental health claims, both work and non-work related. What perspectives related to mental health and functional outcomes can you share?
So this is a big import of our program. As I mentioned, we have the psych screening tools. And as you're probably aware, Social Security disability, in fact, a huge number of the people on long-term Social Security disability have either a primary mental health problem or a concomitant mental health problem. And virtually everybody who has chronic pain has some mental health issues in association with chronic pain. So what's happened historically is in the workers' comp system, these were underdeveloped, right, because the insurers didn't like to look at that part of the picture, and therefore we didn't get it addressed. And we've been pushing, as have the guidelines, again, ACOM guidelines and our Colorado and other guidelines say very early on you have to address this. And as soon as the person appears to have chronic pain and they're having pain beyond the time period and they're not improving in function, which should be essentially recognized in the first 3 months or so, or post-surgery, that you have to have a psychological evaluation, and that psychological treatment is absolutely covered because it's an important part of the recovery process. And I think if we look even in the outside of the return to work and workers' comp issue, again, looking at the Medicare issues, the integrated healthcare model has a behavioral health in all the primary care clinics now as the integrated model and the model in research. So this is a really important area, and this idea of focusing on function means that you're likely to bring this out. Well, I think that personally you should have some psych issues anyway, psych questions or screening at the beginning, that when you start seeing flattening on the functional outcome curve, the first thing you should be looking at is, in addition to your physical exam and stuff, is are there other mental health problems, are there family problems, are there other behavioral problems that need to be dealt with that are interfering with the recovery?
And I know that with, and this is an overstatement, with the Work Strong program, workers' compensation in general, the population that's having recurrent work injuries tends to come out of the cloth of life coming off the cartwheels coming off the cart of life, so to speak. And whether they have, diagnoses that are mental health or not, a lot of issues are also in play that have to do with life balance and managing life, whether it's paycheck to paycheck, transportation, kids, the law, neighbors, environments where you can't walk safely. Just a lot of stuff going on. You add to that some anxiety and stress, which is often part of the puzzle. And so we found that we would try and refer as many people, and we got about 40% of people to go through the EAP program on site for life coaching, and we didn't always call it life coaching or counseling. We often sent them for biofeedback because in many of the cultural groups of employees at UCLA, they just don't do counseling. It's just not part of their approach to solving problems. They might talk to neighbors, family, spiritual leaders, but probably don't do counseling, whereas biofeedback was okay. So they would do that, and that would be kind of a window into helping them address managing other life balance issues.
Let me make a further comment along those lines. So that obviously is a big sensitive issue. So if people don't like to be labeled with depression or general anxiety, it may be a problem in the insurance industry and so forth. So there are other codes for health behavior change. And so a lot of the systems they may be using the same type of people, but they're using the codes for health behavior change as a way to work around some of these sticky issues. And also, again, the patient may not be very accepting of the idea of psychological therapy versus something else.
All right. I want to take a moment to see if any folks in the audience here, the live audience, have questions and give them an opportunity to ask those.
Thank you. My first question is for Dr. Hudson. First of all, I was wondering, it wasn't clear to me whether everyone that had 2 claims was invited to participate or just some people.
Everyone that had 2 claims within the last 2 years was sent to the Occ Health Department by Sedgwick. Each of those claims were looked at to make sure that if somebody was about to sue the university for a civil claim or something, they might put the pause button on that. We had very few people fall out of invitation on that basis. We occasionally had people that were just so injured or ill, comatose head trauma, for example, that medically we didn't think they would clear, but the majority were invited. Now, at best, we got about a third of the people to accept and come through. I think at UCLA we got it up to 40% of people who were invited who accepted. And once they accepted, they generally went through it. They might not have all finished it in the exact 17, 20 weeks. Some people would take a break, pick it up after a month of absence. But started at about 20% participation up to about 40 with more work.
Can I ask another question? Okay, so in the slides that you presented, you had a lot of information to present, so I realized that you have to pick and choose what you show. Do you happen to have any analyses where you looked at the cause of the claims initially and then tracked the results afterwards based on what caused the initial injury?
Yeah, we didn't. We could certainly go back and look at that. That's a very interesting question. We, interestingly, were Switzerland. We were neutral relative to the type of injury, the cause of injury. Occasionally, we would have one fall out when one injury was bitten by an out-of-control pediatric patient on the psych ward 1 year, and 2 years later, stung by a yellow jacket or a hornet walking down the sidewalk. We just thought, that really doesn't have to do with this. So, but it would be interesting to look at all of them, which we did not do.
Thank you. Those were really great programs you were talking about. And I'm just curious what your advice might be to smaller organizations. Obviously UC has a lot of wonderful resources and the ability to put those kinds of resources to good use. But for smaller organizations, when it comes to return to work, functional limitations, things like that, what are some approaches or solutions?
Well, I think for smaller employers, my rule of thumb is people follow people. And so the leadership has to begin to figure out how to walk the talk and lead the culture of health the way they did in operations with safety 30 and 40 years ago. Safety every day, all the time, tailgate meetings and so forth. We have got to learn better to do those same things with well-being and health without tripping over body shaming or confidential areas or things that we shouldn't get into, and yet there's a way to encourage well-being without getting to those areas, but we haven't trained people well. So I think you will see vendors and others, maybe NIOSH, putting together training materials that help smaller employers do that. To build the actual programs, there are some vendors out there that can do many of the parts of the things we did. However, I do believe, like the diabetes prevention programs, there's a core content and a time that's sort of like farming that you can't just ignore. Although some people will be drawn to the apps and the virtual clickable world, and that will work for them. So I think, like diabetes prevention, you will have the in-person group programs, you will have the in-person singular programs, you will have the OMADAs that are more virtual, and so I would look for vendors to get better in this space than the standard wellness vendors have done in the past, because they've mostly gotten 8, 10, 12% traction because they're really not well integrated into the workplace. Like in the early days of safety, we thought insurance companies, and with all respect to Steve, loss control could make safety come alive in the company. It's very hard to do that from an outside occasional visitor. It's really got to be ingrained in every day all the time. And if you go to companies where that is part of their culture, you see that, and that will really begin to have an impact on all these benefit spend buckets as a downstream effect of the improved health. Right. It's either going to be a lot easier or a lot harder, I think.
All right. I think we have time for one more question here.
Thank you again, both. Those were really interesting presentations. Really appreciate you coming out and doing that. So my question is, both of you touched on this, I think, that the individual connection that is made by behavioral influencers seems to me to be an extremely important part of this kind of work. You know, that convincing the employer or convincing the worker that the role of functional outcomes is important, convincing the clinician that it's important. And, you know, Dr. Hudson, you referred to someone suggesting an app for some of the recruitment activities and how that really doesn't seem maybe as useful. Aside from needing a whole army of doctors and nurses and safety professionals to go out and talk to people one-on-one, what other kinds of outreach and convincing type tools do you think we might need or want to explore?
Well, you know, I think if we can get the risk management folks, the insurance folks, the leading employers, NIOSH, and others to beat the drums and lead the parade, others will follow along. And you don't need doctors to talk this talk, really. We picked Ahmed as the people who reach out to invite people in the program because it seemed the safest way to do it that would be appreciated by employees. But I think there are some vendors that are better at reaching out than others. You know, a lot of people get annoyed by the 7 o'clock call from a nurse that you've never heard of, from an organization that you're not sure is even really your insurance company, even though they say they're from the insurance company you have, and it's always at dinner time. But I think there are others that are getting better at it.
All right, I think we're right at that time. So I just want to thank the speakers again, and since we have a live audience, we can do live applause. Let's try that. Hey, it's always funny when you do a webinar, you don't have any that feedback, the positive. So I just want to personally thank you again for coming out to Cincinnati and doing the webinar and also chatting with NIOSH researchers. I think there's a lot of potential moving forward to work with NIOSH, ACOM and NIOSH, and other organizations on this matter. Just as a reminder, the actual presentations and the video will be posted online, and you can always look at that later. And again, thank you for your attention today, and we hope to see you again in another webinar in the future. Thanks.